Good morning, everyone. I'm going to I've got some slides. I've been doing research into AMR or antibiotic resistance and the overuse of antibiotics for 14 years now, which is a while. Definitely seen some changes in that time. I'm going to give you a whistle-stop tour of some of the earliest, going through to some of the latest research that I've done. I think I should probably say, so I'm a social anthropologist by background. What I do is talk to people and work around understanding what people are doing and why, really, rather than the people in the labs who are figuring out why this sort of evolution of bacteria that's causing resistance. Very much a social scientist, and I'm going to be giving that perspective now. I'll just remind myself how to share slides. My share. Can you see my slides yet?
Yeah, perfect.
Okay. I can see people. I think do feel free to sort of shout out or put your hand up if that's a possibility in Zoom while I'm talking. But I should be done in a not too won't be talking for too long so that you can then ask questions afterwards. So this is broadly what I do research on, understanding and reducing overuse of antibiotics in the UK and globally. Generally means doing a bunch of research to understand what's driving overuse of antibiotics and then doing some research to develop interventions to try and reduce that. So this is a little kind of a guide to what I'm talking about today. I'm going to talk about antibiotic use with respect to children in the UK, and then quite a little bit on that, a little bit on older people living in care homes, and then people living in lower income countries, sort of internationally. Children and older people are both groups who get a lot of antibiotics, and that's partly because they are more prone to illness, and it's partly because of beliefs around them and our need to protect them. So this is children with cough. So I'm going to just minimize that. Yeah, there we go. I can't see my own slides. Children with coughs get too many antibiotics, and so this is children, and I'm sure there are many parents in the room. As we all know, when they're quite young, children start, and as soon as they're sort of out there in the world, kind of interacting with other children, they bring home every lurgy going. They can go, the whole of their first winter, they're just getting cough after cough after cough, runny nose, sore throat. And some of them don't seem that bad, and some of them can be a bit scary, and they have quite high fevers, or they have quite rattly sounding chests and things like that. And so what happens is parents are going in to the doctor with their children with these cough symptoms or respiratory tract symptoms, if we use the medical term, quite high numbers of them, right? When the children, particularly the under five, seeing lots and lots and lots of the GP's work is seeing these children under five with respiratory tract infections. And of course, in the UK, antibiotics have to be prescribed by a doctor. So the only thing that's in the gift of the parents to do is to go and see the doctor. And then once they get in there, the doctor has to decide, do I want to give this child antibiotics or not? And most of them they don't give antibiotics to. It's probably around 60 to 70% of children who go in to see with a cough don't get antibiotics. But there's still sort of 30-40% that are getting antibiotics, and that is still way more than actually need antibiotics. The problem is that it's quite difficult for people to tell, including doctors, which ones would benefit from antibiotics. And so what's happening is there's an uncertainty about which of these children is going to be okay regardless, and which of these children might get seriously ill and might actually need antibiotics. From the parents' point of view, they're thinking I think it's safer to go and see the doctor. And the doctor's point of view, they're feeling I have to be really sure. I have to feel quite brave not to give antibiotics. And so this is what came out of this early work with the understanding why we see really high rates of antibiotic use for children with respiratory tract infections, is because there's a lot of uncertainty about which children might actually need antibiotics, and it's quite low numbers, right? So of the children who go to see a doctor, probably only 1 in 100 actually needs antibiotics. But currently, about 40 in 100 get antibiotics. So even though it's not most of them don't get antibiotics, we're still kind of massively overprescribing antibiotics. And it's because you can kind of imagine, right? So from the point of view of the parents, why all these parents turning up when their child isn't even that well? Even though the parent might feel that it's not very likely that their child is going to need antibiotics, if they get it wrong, their child could become seriously unwell or even die. And the consequences of that is massive. So even though the chance is low, the consequences are terrifying. I can see Peter Clark has raised a hand, please.
I was wondering, are those figures worldwide or UK?
Oh, worldwide.
Thank you.
You see similar. In fact, the UK is relatively good in terms of not overprescribing. So in the US, I think the prescribing for children with respiratory infections is like most of them would get antibiotics, maybe 60, 70%. So yes, and then for the doctors themselves as well, it's that thing with the children, they are more vulnerable, but they're also, because in society they're perceived to be vulnerable. We feel that we as adults carry a lot of responsibility towards making sure that children are safe. And if as a GP you missed it, the consequences, for the child and perhaps even for yourself would be quite serious. And so there's this that kind of drives. This was the big story, really, is that the kind of the overuse of antibiotics for children with cough was this series of good intentions and people trying to do the best for the child in front of them at every step. And I think the other thing that we really saw in this particular study was the different patterns of experience. And so for lots and lots of parents, their child gets sick in first few years, and they get lots of sickness. They go to the doctor the first few times, and the doctor says it's just a virus. Don't worry, they'll get better on their own. And indeed, that is the case for the majority of parents. And so for those parents, they eventually learn to think of respiratory tract infections as being no threat at all, and just a virus, and we don't even need to worry about that, which isn't also quite true. But for a small number of parents, they can have really serious, the experience of their child getting very seriously unwell, hospitalized. It's even sometimes, respiratory tract infections kill a small number of children every year. They sometimes implicated in sudden infant death as well. And that is absolutely terrifying. And of course, as always, these different experiences, the really serious experiences, are more common in poorer populations, in more marginalized groups. And so that's why you tend to see higher consulting rates from those groups, because their experience is that it is more dangerous, because in some ways it is for them. So this is a little intervention that we developed in order to, we co-designed this actually with 4 different groups of parents from different kind of demographic groups in Bristol. And we developed something that was trying to help them navigate these symptoms and to understand what was going on, which has been sort of widely used actually by doctors who sort of direct parents towards using it. So this is one of the first interventions that we developed to try and make sure that parents who were bringing their child to see the doctor they're trying to make sure that they're only coming if they really did need to be seen. And it's still kind of way more than actually need antibiotics, but it's still kind of, in reducing the numbers, can help contribute to that problem. So I've also done a small project in the Children's Hospital in Bristol, which is really an excuse to put a picture of Wallace and Gromit on the screen, because they are the charitable, they do a lot of charity for the Children's Hospital, and they're all pretty much all over. I don't know if you've been in there recently, but they actually, there's a Gromit voices in the lift, which is quite fun the first time and kind of annoying after the 10th, to be honest. But I digress. This is so what we were looking at is trying to reduce antibiotic use in the Bristol Children's Hospital. This was with a lovely infectious disease consultant who works there. and she was trying to implement some strategies to reduce overuse of antibiotics. And what you see is it's different because it's different when in a hospital setting, but it also has some similarities to what we saw going on in the community. So what happens when children turn up at hospital if they are quite unwell, if they have a high fever or a very very wheezy chest or something, they're immediately put onto antibiotics before they have any idea what's wrong with the child, right? They haven't done any of the tests, they haven't got any results back, they haven't really, done any screening or anything, but they put them on antibiotics immediately because it's a very unwell child. And even though they don't know what the cause is yet, if it is a bacterial infection, then you need to put them on antibiotics immediately because waiting for the test is going to be too late. So they put them on antibiotics immediately and then they run their tests and they try and figure out what's going on. But what she found was that once they did know what was going on, if it wasn't actually a bacterial infection, they didn't necessarily stop that course of antibiotics, which they should have done. And it was kind of because the doctors felt like it was kind of just in case. It was that thing where, we're pretty sure that this is a viral infection or it's some other cause altogether. It's not actually an infectious disease. But are we sure enough to stop the antibiotics? And she was kind of essentially working with her colleagues to say, look, we are sure, we have got the evidence here. We can safely stop these antibiotics because it has lots of bad consequences as well, taking antibiotics that you don't need. It gives them a lot of gut problems. There can be other knock-on problems, and there are issues down the line sometimes as well. So she did a lot of work with that, and we did a little evaluation looking at the same thing, and we found the same themes of this uncertainty and this need to keep children safe that was really driving what was happening. This is a completely different project here. We also did some work in care homes. And I think there's some parallels, even though the populations are very different. What you have are people who are kind of not able to care for themselves independently anymore. So these are care homes where they're not able to live independently. They are being cared for. And so other people have some responsibility, just as parents have responsibility for children. Other people have some responsibility for making sure that they are safe. And so again, we were seeing some of the same kinds of issues around kind of overuse of antibiotics and doing antibiotics just in case when actually the symptoms weren't caused by an infectious disease at all. And so one of the approaches we took here was to try and reduce the transmission of infections, because there's a real issue in a lot of care home settings where you get infections that pass from person to person. And so you have one person after the other going down with an infection, and then you have a lot of antibiotic use and then a lot of antibiotic resistance in that setting. And so we did an intervention to sort of try and understand what was getting in the way, because of course care homes have really good infection control protocols. Usually all the staff is that you're supposed to wash your hands many times a day, you're supposed to clean all the door handles, you're supposed to wipe everything down, all of this kind of thing. So they had really good plans, they had really good training, all of that, but still they were getting infections. And really what was happening is it was when their carefully laid plans were kind of interrupted by something else, which might be because somebody was in danger of falling, and so you would sort of deal with that problem and then forget to wash your hands or forget to wipe something down. And so we actually in the process of developing a little intervention to try and address that, which is quite tricky to do. So you're trying to train people to kind of remember to do your infection control after you've dealt with whatever has interrupted your normal process. Okay, and so finally, I'm going to talk about some work we did in low and middle income countries. My colleague Tingting is going to talk about the work we've done in China, so I won't discuss that. But just to remind you, a little map here, you can see that the dark green, that's the high income countries. Low and middle income countries, that's everywhere else. So it's pretty much, it's all of Africa, most of South America, most of Asia, and includes Russia and quite a lot of Eastern Europe as well. And so the problem in these settings is quite poor living conditions, which means that there's really high rates of infection, much higher rates than we would see here in the UK. there's also really poor healthcare services. So unlike here, where you can eventually, I admit, get to see a GP, there are many people without access to, trained medical professionals at all. I mean, sometimes it might be mobile services, it might be because it's inaccessible, but it might be because there just aren't any doctors, right? So they might have a hospital, but no actual doctors working there, or no drugs available. But what you do see is that if you do go to see a doctor with any kind of infection symptom, there's really high antibiotic prescribing rates, much, much higher than we see here. So you might see 80 or 90% of people who turn up with a fever or a cough would get antibiotics in these settings. There's also, it's really, really common for people to be purchasing antibiotics for themselves from shops. So antibiotics, unlike here, where you can really only access them from a trained medical professional, in most of these countries, you can buy them kind of over the counter, the same way that we would buy aspirin or paracetamol. You can buy them from shops, you can buy them from market stalls, you can buy them from mobile peddlers. And that sounds like a bad idea, and in many ways it is, but for lots and lots of people living in these countries, that's the only way they can access medicines. They would have no other access. And these are sometimes life-saving medicines. And so there's this real tension between making sure that the population can get access to medicines and trying to constrain overuse. Because a lot of the people who are delivering these medicines are private businesses so the profit motive comes in and promotes sales. So we have high antibiotic prescribing and we have high antibiotic sales, and that becomes really normal practice. And I think it can sometimes explain some of the problems we see here when we've got people who've migrated from contexts where high antibiotic use, prescribing and sales and easy access is completely normal, to come into our setting where it's highly constrained, is very confusing and can give a lot of challenges, I think, in primary care practice, where it's quite difficult to sort of try and unpick and address some of the source of the confusion. Oh, and I've got two versions of that slide for some reason. Forgive me, I did my slides just today. And I'm going to end there. Thank you for listening. I will stop sharing so that we can see each other.
Brilliant. Thank you ever so much, Christie, for giving us such a fantastic overview of the range of work you've been doing. That was really, really interesting. Just in the interest of time, because it's past now, and I know we've got another two speakers. No, not at all. Should we go hand over to Tingting? But if you do have any questions for Christie, please do pop them in the chat or just keep a note of them, and then we'll try and finish a bit earlier so we can get some questions in as well. But thanks so much, Christie. That was brilliant. Okay, so yeah, I'll hand over to you, Tingting. Thank you.
Hi everyone, really nice to see you all. And I am a senior research associate in the University of Bristol, and I am a qualitative researcher. So what the research method I use is the interview and observation or focus group discussion, which is a bit different from the statistics thing or the lab thing. So currently I'm working with Christie to design the intervention to reduce AMR in the UK. But before this one, I was working for a China-focused AMR project. And I was also working with Christie to design an intervention focusing on the China context. And today I'm going to share some details about how we designed and evaluate this intervention. So it will be an example of what the intervention looks like and how we evaluate them. Yeah, just share my screen. Yeah, looks okay. Yes, so right, so the AMR, as Christy said, it is, I think it's more affects the low and middle income country, and also it is a severe problem in China. The antibiotics are overprescribed, particularly in the rural primary care in China. But the primary care system in China is a bit different from what we have here in the UK. So the primary care system in the rural part of China is consists of the township health centers and one level below them as village clinics. So this is a picture of the township health center I took in the field visit. So it is a bit larger scale than the village clinics, and it has both inpatient ward and also outpatient clinic. Staff working there usually obtain a formal medical training. But this is a typical township clinics. You can see it smaller, and it usually have just 1 or 2 rooms as a clinic room, and it only offers the outpatient care for patients. The staff working there, we call them village doctors. So they usually don't have the medical degree, and the training they obtained varied a lot. Some can be very limited. So we conducted our study here in Middle Province, Anhui Province, in this red one, and before this intervention design study, the research team has conducted a lot of research in the rural primary care in this province, and they found nearly 90 of the RTI or UTI patients were prescribed antibiotics by the practitioners in rural primary care there. So in this study, we want to design an intervention to reduce antibiotics prescribed by the practitioners for the RTI patients. Yeah, so this is the process, like how we designed our intervention, and we follow a person-based approach that we want the target user of this intervention felt it's easy to use and it's easy to engaging. So you can see this circle. So we create our intervention elements mainly by the interviews and observation we conducted in the field. And then once we got the elements, we brought them to the real user, the practitioners, and also including the patients, and ask their feedback. And then we redesigned our intervention based on their feedback. So we repeated this process 5 times and talk to 37 practitioners and 18 patients until we got the final intervention. Yeah, so this is an overview of what the intervention looks like. So it is a complex intervention and have multiple components. It has 5 components, and all the components will work together to change the practitioner's prescribing behavior. I'll just quickly go through each one. So we designed a practitioner training. We delivered it at the beginning of the implementation, and it just helped the practitioners to remind them that antibiotics are not recommended for the most RTI, and also give them some most latest evidence about the antibiotic use evidence. We also picked up a peer support group for them, so they can discuss with peers when they have a problem or challenges. Then we designed the public letter of commitment and patient leaflets for them, and they can use them at the clinic and display in the clinic. And also they can give the patient leaflets during the consultation to patients. finally, we designed a prescribing decision support tool. So help them to help them with the prescribing process in the consultation. They say that so all of them will work together. So this how we kind of evaluate the intervention. So our study finally focused on the township health center because the impact of COVID-19. So the village clinics were not allowed to see the RTI patient for a very long time after the COVID-19. So we only focus on the township health center. And then this figure shows how we collect the trial data. We implement our intervention at the December 2021. You can see like the COVID-19 still interrupt the data collection for a long time until the June when the team returned to the field, and then the number increased very quickly, and we met the target number at September. But in between, we also use some qualitative methods like interviews, observations to evaluate the intervention. Yes, so we observed the training when it was delivered in the December 2021, and also after we implement the intervention, we talked to 24 prescribers about their views and feedback of using the intervention. So the overall feedback are very positive. So they like the intervention and they felt it was useful. But we got some issues about some specific components. So there are some usability issue about a computer-based decision supporting tool, because at that time the practitioners, they also have a very similar online prescribing system. They have to use it, which is required by the government. So using our online system at the same time means double the workload and the working time. So they find it's difficult to use that one. And also there's some issues about starting a peer support group discussion, because like they working as a group and have some discussion is a very new thing in the primary care in the China system. So people mainly prescribing based on their personal experience. So they find difficult to understand the rationale of this one, and therefore difficult to start it. So based on their feedback, we designed a intervention booster and delivered it in June 2022, which we just addressed the issues we find from the interview. Like we make a one-page laminated poster as a decision support tool instead of the computer-based one. And then we also talked to a few more practitioners, and this time the feedback was really good and encouraging, so they like it and use it a lot more. And finally, we also analyzed the data collected by the trial, and the outcome is also very positive. So the antibiotic prescribing rate from the intervention group is like significantly lower than the control arm. Yes, and we just got our outcome published. And so finally, the final slide and just some summary. We find that based on the outcome from the trial and our qualitative evaluation, the complex intervention is effective to reduce antibiotic prescribing for the RTI patients in the rural China. And we also find the importance to respond to the local context, like how the local primary care works and how to respond to some suddenly happen, like the outbreak of the pandemic. Yeah, that's it. Thank you.
Thanks so much, Tingting. That was so great to hear about the work and the positive outcome that's come from it as well. So congratulations to you and the team for that work. I'm sure that people will have questions for you. I can see there's already a few comments in the chat. But again, just is it okay if we move on, Tingting, to Emma, and then we can come back at the end if anyone's got any questions for you about that work. Great. Thanks so much. So I'll hand over to you, Emma, if that's
Yes.
okay. Thank you.
Yeah, I'll just share screen, hopefully. That's probably not the right screen. Or was it the right screen?
Yeah, we could see the presentation, just not in like the full.
Oh, okay.
Yeah.
Second try. I'm not a Zoom user. I usually do Microsoft Teams, so that's my excuse. Okay. Right, we're all set now. Is that good?
That's great.
Okay, fabulous. Okay, so hi everyone. I'm Emma, and I work at the Bristol Trial Centre, and I've been working on a study which has just recently, well, it's being analysed right now, so we'll have our results very soon. And the trial is called the Rapid Test Trial. So Rapid Test is basically a trial which we're running in GP surgeries around the Bristol area. And we are testing what we call a rapid point of care test machine, which I will show you a picture of in a minute, and I will go through how it works. We're using this machine to see if we can reduce the amount of prescribing that's happening at GP practices for respiratory tract infections. So obviously, with respiratory tract infections, as the previous two presenters have alluded to, in general, it's very overprescribed. Over sort of half of antibiotics that are prescribed for respiratory infections are considered inappropriate. So we're using this trial to see if we can use this special machine to try and reduce the amount of antibiotics which we're giving out. So with our trial, what happens is we would take a nose and throat swab from every participant that comes into GP practice with a respiratory tract infection, who have obviously consented to be part of the trial. And they would randomise to either have their swab tested on the machine or to not have it tested. And our point of care test machine is basically a big PCR machine, which everyone's a bit more familiar with after COVID. And it churns away and it checks for overall 23 different microbes. So it's a mixture of viruses and also atypical bacteria. So that could be like, the viruses range from like pneumonia, COVID, can't think of another one now. And then there's atypical bacteria as well, so pneumonia and things like that. So this is what the point of care test machine looks like. So there would be one of those in each of our GP practices. And you can see where the little L-shaped sort of slots are. That would be, this is very technical, but I just thought I'd show it for interest, is where we would load in the sample and we add lots of special ingredients to it, and then it gets slotted into this L-shaped bit. And the machine runs and it checks for all of the different microbes. So I thought I'd just share some good news as well, because keep it light. So we finished our recruitment actually 5 months earlier than we thought we would. And we randomised in total 552 patients across Bristol. We did over 16 GP surgeries. So we had what we called 2 winters. So we had 8 GPs doing this in winter 1, and then the next winter we had different 8 GPs running it. And this was between the end of October 22 and April 24. So that's good to see. So I'm going to tell you a bit about why the trial worked well, why we thought it worked well, and why we managed to recruit lots of patients to this trial. So the first thing is, well, also this is interest, but the first thing is we had a very manageable scope of sites around Bristol, which meant that we could offer a lot of support to the sites, including with our research nurses. If you're from Bristol, you might be able to see your GP surgery on there, but it was a nice local range that we had. We had a lot of eligible patients for this study. So as you can imagine, in winter time, there is a lot of respiratory illnesses going around in any workplace or anywhere you hear people coughing, spluttering. There's a lot of germs around. So sites could screen patients. They would get their patient list in the morning. They could screen it for anyone that was coming in with any sort of respiratory infection symptom, and they would be able to see if they wanted to be part of the trial. But actually, we did find this year that's just gone is that even recruitment in the summer was double what we originally thought, which means obviously people are still getting these kind of infections over summer, especially COVID. Actually, people were tending to get in the summer, which was quite unusual. The trial actual process that we had was it was acceptable to both the clinicians that were taking part in the trial and also the patients. So when they had the swab taken, we think that it was very acceptable to people because people have had a lot over COVID. Before COVID, I don't think probably there was some of us who'd never had a nose or throat swab before. But now it was such a common thing that when you come into the GP and someone says, would you like to be part of a trial? All that we need is a nose and throat swab. They were very much like happy to take part. It only takes 45 minutes for the sample to run. So once you've had your swab, it goes into the machine and churns away for 45 minutes. What would happen is the patient would go home and then the doctor would ring them up later and tell them what the result of their test was, whether it had identified any virus or bacteria. And they would then be able to give them their prescribing decision. So it wasn't as if the test took a long time. It was quite a short and snappy thing, hence rapid test. We also had e-consent, which made a big difference because people could easily just use their phone or a laptop to consent instead of the written options. We did also have that, but it was just a nice quick way to get people to take part in the study. And also the clinicians were just really interested in this point of care test machine and how it might improve care for their patients, how it might reduce the amount of antibiotics being prescribed. And it's just really interesting when you are able to see exactly what someone might have. We also did do a lot of qualitative work about the clinicians' opinions about this technology and also the patients' thoughts about it. And there was a lot of mixed thoughts. There was, there was differences in some clinicians thinking, might this technology sort of maybe undermine clinician trust. A lot of others found it really, really helpful for diagnostic as a tool. But the main results of that will be coming out soon. We can go into more detail about it. We also had, I feel like this feels like a shout out to our research nurse Lynn, who's not here, but she worked with us on the trial and she was able to, when I showed you the map of Bristol, she was able to go to all of those sites and get a really good relationship at sites with the team members and visit them early. She could sort out any problems that came up sharp before they became a real problem. And also, there's a lot of GP sites they're busy people. She could provide cover when they were lacking staff so that we could keep that recruitment going. And she was really big asset to the study. We obviously did face also, it's not all easy and happy. We had some challenges for rapid tests. So as I said, we did set up 8 sites to begin with. We had 8 of those PCR machines and they recruited for one winter. And then we had to manage getting 8 machines to 8 different GP surgeries across Bristol and close and set up practices while some were still recruiting, which was quite a challenge. We also asked our participants, once they'd had their swab and their prescribing decision, to fill in a trial diary for us. It was about their symptoms, were they feeling better, which medication they were taking, and that allows us to see whether also the point of care test might have an effect on that symptom severity. Were people who had the test, were they feeling better sooner? Did they have worse symptoms? So, but getting people to complete trial diaries is often quite difficult because they're feeling ill. They might not want to commit to spending time doing questionnaires. So trying to find techniques to get more of those back was a challenge. We did also take on some more sites in Winter 2 who hadn't necessarily done any research before, which was a challenge because they're less experienced, but actually I found that they were really, really interested and really willing to learn, and they wanted to be part of research. And this was a really good trial for them to be sort of introduced to research too. And then the final challenge was just that in winter, it's flu season at the GPs. It's a very busy time, lots of clinics being arranged. So we had to work around that with our own study. I think that's actually the end of my presentation. It was like a quick run through, but obviously now there's time for questions and stuff, so happy to take them.